All right, so let's go ahead and get started. First, I want to welcome our wonderful panelists, Dr. Lucinda Grand, Dr. Jeffrey Singer, and Mona Bennett, and I will let them introduce themselves in a little more detail in a few minutes. First, I wanted to briefly chat about why we're here today and why we're even having this conversation. So in 2021, right, opioid overdoses killed more than 200 people a day in the United States. While any opioid use comes with the risk of potential overdose, there's the growing presence of fentanyl and other potent synthetic opioids that amplify it, right? So since 2016, the majority of opioid-involved deaths in the US have been due to fentanyl and related substances. And the magnitude and persistence of the overdose crisis has left policymakers at all levels of government looking for solutions. Sometimes this has meant increased criminalization, and other times it's taken the form of public health oriented strategies such as harm reduction, right? But so what we're hoping for today is to talk a little bit about the intersection of the rise of fentanyl, harm reduction strategies, and criminalization. So harm reduction, for folks who aren't super familiar with it already, is a pragmatic and evidence-based approach that trades an abstinence-only ethos for one that meets people where they're at, right? So it's providing them with tools, knowledge, resources to care for their own lives and health, right? Even if they're not able, ready, or willing to stop engaging in a so-called risky behavior. Most of us engage in some sort of harm reduction on a daily basis. If we're driving a car or riding a bike, we might throw on a seatbelt or put on a helmet. If we drink alcohol, we might decide to have one drink instead of 10. So our panel today includes I'm super excited about having these three folks here. We've got experts in policy, treatment, and harm reduction. And together we're going to discuss how policy has precipitated the rise of fentanyl in the US, how fentanyl's proliferation affects risk and risk management for people who use drugs, and how harm reduction supportive policies, from decriminalizing fentanyl test strips to expanding access to the overdose reversal drug naloxone, as well as medications for opioid use disorder, can save lives. So before we jump into the conversation, I want to go ahead and let our panelists introduce themselves. I am going to start in alphabetical order. So if we can start with you, Mona Bennett, please.
Good afternoon or morning, y'all. I am Mona Bennett with the Georgia Harm Reduction Coalition. We've been around for 28 years. On my new GHARC badge, it says ambassador. That covers many things, but I especially do street outreach, and I sling a lot of Narcan.
Thanks, Mona. Let's go ahead to Lucinda Grand.
Yeah, thank you. I'm Lucinda Grandy. I'm a family physician and addiction medicine specialist in Olympia, Washington. I received my medical degree at the University of Washington School of Medicine in Seattle, and my family medicine training at Providence St. Peter Family Medicine in Olympia. I have been a primary care provider at Pioneer Family Practice for 11 years. About 10 years ago, I began to prescribe buprenorphine there. That is the active ingredient in Suboxone and is useful for both opioid use disorder and also for pain management. In 2019, I was co-founder of the Olympia Bupe Clinic. OBC is a busy, low barrier, harm reduction, peer facilitated walk-in buprenorphine clinic for high-risk people with opioid use disorder. I served as medical director there for 3 years with responsibility for treatment of about 1,400 patients. I'm going to tell you a little bit about Olympia Bupe Clinic so you kind of understand where I'm coming from. The clinic provides buprenorphine to patients at their first visit. We think of it as medication-assisted harm reduction. The emphasis is on providing a welcoming atmosphere with a culture of kindness and compassion. Peer support specialists are a prominent aspect of care. There is on-site medication dispensing, individualized dosing, and no cost for visits or medication. There is no commitment to recovery required and no required counseling, although counseling is encouraged for those who are able to access it. This treatment strategy is particularly important for people at the highest risk of overdose death, those who are justice involved and or have complex medical and social needs, including unstable housing. And it's also important for people who are pregnant, who paradoxically have a hard time getting access to treatment because medical providers are afraid of causing harm to the fetus. About 40% of patients at OBC also have chronic pain, often having been cut off from prescription opioids by their medical providers. That's another topic for another day. But thank you for inviting me.
Yeah, thank you, Dr. Grandy. And Dr. Jeff Singer.
Hi, thank you for having me here. I'm Jeff Singer. I'm a general surgeon in private practice. I graduated New York Medical College long time ago, longer than I want to admit. And I became board certified, started a private practice, became a fellow of the American College of Surgeons, always had an interest in public policy. And the last, basically most of this century, I got involved in public policy. And I'm also a senior fellow at the Cato Institute in the Department of Health Policy Studies, where a great deal of the emphasis of my work is on the overdose crisis, harm reduction, and drug prohibition, among other things.
Great, thank you all. And thank you for bringing we've got a nice round, diverse set of expertise and experiences here today. So I'd like to start our discussion out by talking a little bit about how we got to where we're at, right? So to give just an abbreviated sense of fentanyl's proliferation in the US drug market, we're talking, first of all, to clarify, we're talking about illicit fentanyl, not the fentanyl that folks are prescribed or given in a medical setting, right? We're talking about the proliferation of the illicitly produced version of this drug on the market. And we really first started to see it emerge with any consistency and on a larger scale in about 10 years ago. But it didn't just all of a sudden hit the US drug market, right? It has saturated different parts of the country at different times. And what that means sometimes is that the experiences that folks on the ground have had in different states has looked different. And it means that the policies that have emerged in response may have come about on a different timeline, in part because they've been facing different realities. So, and starting in about 2016, that's when we started to see consistently fentanyl was responsible for the majority of opioid overdose deaths in the United States. And so thinking, just for folks who aren't super familiar with this, we all hear about the fentanyl crisis. Why is fentanyl itself so challenging? Why is it leading to so many deaths? Part of this is that it's substantially more potent than heroin, about as much as 50 times more potent than heroin, and I believe more than that for when compared to morphine. It's also, it tends to have a narrower threshold in terms of desired effects that folks might want, and when it starts to get really dangerous. I will let the doctors speak more specifically to that where it's relevant, but that's part of what we're seeing. And what we've been seeing is it's showing up in pressed pills, in heroin supplies, and we're increasingly starting to hear about it show up in stimulant supplies. So to start us off, I'm wondering, Mona and Lucinda, let's start with Lucinda this time. Can you talk a little bit about when you first started to see fentanyl become a concern in your community? And just like, did it show up immediately? What did that look like when we first started to see it?
Yeah, so in my community, heroin was the prevalent illicit opioid until late 2020, early 2021, when fentanyl started infiltrating the drug supply. At first, it was mixed with heroin, and people were often unaware of that. Fentanyl test strips were getting used to help people know what was in their drugs, and they would use smaller test doses when they discovered that there was fentanyl in their supply. Over time, however, fentanyl became more prevalent and some people started actually seeking it out due to the intense high. By late 2021, early 2022, it was actually harder to find pure heroin, and most people knew that they were actually primarily using fentanyl. Over the course of 2021 and 2022, fentanyl also was infiltrating the methamphetamine supply, and test strips started to become more useful for testing the meth supply. There was a lot of inadvertent exposure to fentanyl over the course of this time. People started becoming dependent on it, and in some cases dying from fentanyl overdose, even when they thought that they were just using meth.
Okay, thanks. Yeah, and Mona, if you can jump in and share.
Sure. We started seeing fentanyl being mixed in the heroin 2012, 2013. Luckily, the Georgia State General Assembly, our state legislature, passed our 911 medical amnesty law and the naloxone access bill in one session in 2014. We were honestly expecting to have a multi-year battle, but due to great work by the Georgia Overdose Prevention, the bill passed nearly unanimously, both houses, signed by the governor in the legislative session of 2014. So we could do a lot of education around the growing mix of fentanyl and heroin. And about 3 years ago, we started seeing, about 3 years ago, 2019, 2020, we started seeing more fentanyl in stimulants. And 2 years ago, we had a particularly bad rash of cocaine-laced fentanyl overdoses and deaths all over the city. And we heard from our friends in other parts of Georgia where they were seeing more fentanyl in stimulants. So we are distributing a lot of naloxone hydrochloride, Narcan. And our statewide distribution partners, Georgia Overdose Prevention, they can't keep it on the shelves. So we're just trying to keep up and educate all who we can, because it's still a bit difficult, but it's getting less and less difficult to convince stimulant users that yes, you do have to have Narcan on hand, never use alone. Yes, we have free excuse me, I'm struggling with my little CPR face mask. Get plenty of these. It's a little keychain size face mask. Looks like a plastic mask with a one-way valve, because oxygen is vital when reversing an opioid overdose or fentanyl overdose. So everybody needs to get these. Anyway, it is getting easier to get stimulant users to use Narcan.
Yeah, so it definitely, I think this is sort of a powerful example, right, of how what the presence of fentanyl has emerged really differently in two different states, in Washington and in Georgia. And then also it's affected the communities and the folks who are using a little bit differently as well. So one of the things that we see rise up, and we're going to jump into a more explicit talk about harm reduction in a moment, but one of the things that we've really seen an awful lot is calls for harsher laws to target fentanyl and related substances, both at the state and the federal level. We've seen class-wide scheduling of fentanyl-related substances at the federal level, and we're starting to see more states come up with their own versions of this. But there's a little bit of history that indicates that this is probably not going to be the most effective approach to saving lives. So, Jeff, I'm wondering if you can talk a little bit for us about the connection between drug policy, especially drug prohibition, and the rise of fentanyl.
Sure. In fact, the fentanyl crisis is the direct result of drug prohibition. Policy economists and drug policy experts use this term, the iron law of prohibition. Basically, in shorthand, the iron law of prohibition says the harder the law enforcement, the harder the drugs, because it makes economic sense. It incentivizes people who are marketing whatever is prohibited to come up with more potent forms that could be smuggled in smaller sizes and could be subdivided into more units to sell. So the more risks you impose, the more the more you're incentivizing cartels and other drug dealers to come up with more potent forms. During alcohol prohibition, they weren't smuggling in beer and wine, they were smuggling in the hard stuff. Even today, another real world example is when people are tailgating at a football game. They're drinking beer and wine out in the parking lot, but you're not allowed to bring any alcohol into the stadium, and they're bringing in the hard stuff in flasks, not the beer and wine. So it's prohibition that made the THC concentration of cannabis get stronger over the years. It's what helped bring crack cocaine into the market. Might not have even existed. Powder cocaine was around, but if it wasn't for prohibition, we might not have had crack cocaine. And it's what made fentanyl start to show up around 2012, 2013. And one of the reasons why it's become more popular for the cartels, and this, by the way, was energized by the COVID pandemic, is during the pandemic, the border closures and supply chain issues made it difficult to get the opium poppy to where it needed to be processed. And also there were supply chain difficulties with the industrial chemical acetic anhydride, which is used for a lot of things. So meanwhile, there was not a supply chain issue with the substrate piperidine, which is used to make fentanyl. So fentanyl is easily made in labs, just like meth is made in labs, and it doesn't require growing and transporting a plant. So it could just be synthesized. So during the pandemic, it became particularly more practical for the cartels to switch out heroin for fentanyl, but it was already starting to emerge as a way to make heroin more potent so that it could be smuggled in smaller amounts. Now, by the way, I don't think I've said this on a number of occasions, and I'd like to hear what our other panelists have to say about this. We've been starting to see, first of all, xylazine show up, which is a veterinary tranquilizer. Users call it tranq, which unfortunately can't be reversed by naloxone because it's not an opioid, and it's a very powerful tranquilizer that potentiates the strength of fentanyl. Again, that's the iron law of prohibition, because it's given the cartels a way to make it more potent so it could be smuggled in smaller. And also, since around 2019, health departments both in the US and Canada and Europe have been reporting the appearance of another synthetic opioid called nitazene. Was originally developed by Ciba Geigy in the 50s, never came to market. It's estimated to be about 20 times the strength of fentanyl. And that's been showing up now, because most toxicology labs are not testing for it. We really don't know how prevalent it is, but just this past fall, the Tennessee Department of Health announced that nitazene-related overdose deaths increased fourfold since 2019. So it may turn out that a few years from now, we're having a panel discussion about the nitazene crisis. And as long as our policies are aimed at just doubling down on making it more and more law enforcement and more difficult for the drug cartels to basically supply the market demand, because it's not like people talk about this, we have an invasion of fentanyl, we have an epidemic of fentanyl. No, it's not a virus that goes around searching for hosts or a predator that seeks prey to attack. It's a response to market demand. And as long as we make it more difficult, we're actually fueling the development of more potent forms, and it's only going to get worse.
Yeah, I think that intersection between criminalization and the potency of the substances that we're seeing, as well as the level of involvement of different criminal organizations, is a fascinating one, and also an unnerving one, right? I spent about 5 years conducting ethnography with folks who were actively using methamphetamine in northern Colorado. And at the beginning of my study in the late aughts, people were purchasing meth from local cooks, mostly people they knew, right? And it was more likely to be crank, so it wasn't as potent, but they knew exactly what they were getting. They could pick and choose among cooks. And then as restrictions on methamphetamine precursors increased and I started to notice like I could no longer purchase, I couldn't get Sudafed anymore, right? Without showing my ID and going through jumping through a bunch of hoops. Around that same time, I started to notice my research participants were saying, yeah, you don't really want to go talk to the people that we're getting the methamphetamine from anymore, because now we're getting meth from cartels. That's where it's coming from. And so what we were seeing was a shift in not just the drug that was being produced, because all of a sudden they were getting, instead of crank, they were getting crystal meth. But we were starting to see a shift in who was controlling that market at the same time in response to the types of prohibitions that were popping up. So at least through the eyes of my participants and what I saw, it seems like we really do. We see this. We saw this with methamphetamine. We're seeing it now with fentanyl. Yeah, Jeff.
It's interesting that the cartels really weren't in the meth market until Congress passed the Combat Methamphetamine Abuse Act in 2005. So now we can't get Sudafed very easily, which is an excellent decongestant. And a good 10 or 15 years ago, the cartels moved on from Sudafed to much more efficient and potent ways of making methamphetamine. And I heard a comedian, this is sort of dark, but it's kind of true. Comedians say he knows a lab that's converting meth into Sudafed for people who are having trouble getting Sudafed.
Yeah, the dark gallows humor type approach to this at this point. Lucinda, did you have something you wanted to add?
Regarding trank, I think was that one of the topics was we don't have that yet in Washington. I just saw a webinar put on by the University of Washington Addictions, Drug and Alcohol Institute, and they know like what is going on in Washington State and across the country. And they said that it actually there's very little evidence of xylazine in Washington State so far, but we're anticipating it will not be very long before that starts to infiltrate the drug supply here.
We are seeing it in Georgia, the metro Atlanta area. People are reporting symptoms of blackouts, and these are people who used their longtime opioid users. People are having sores where not at their injection site. People are describing the sensation of taking sleeping pills. So xylazine, trank dope is here in Georgia. Also, I forget the scientific name you gave, nitazene.
Yeah,
Xylazine.
Yeah.
On the streets, it's known as ISO, I believe.
Yeah.
And then there's the companion drug, pyro. It has an even longer scientific name, but we're starting to hear about those in metro Atlanta.
Yeah, nitazene is just kind of the generic term. Isotonitazene is one of the products, so that's probably why they call it ISO for short. And yeah, but it's a category, just like nowadays when we say fentanyl, that they're fentanyl and analogs.
Yes. So we need to keep on looking forward to make sure that we are responding as opposed to reacting to these new and more powerful substances. They're just going to keep coming.
Yeah.
Yeah, they really are. Oh, go on. I don't want to.
I could, if you want to talk about how they keep coming. First of all, I think one of the reasons different parts of the country see different combinations has to do with supply routes. And it's not like one monolithic cartel. There are different groups. So in some parts of the country, it's easier to get things in than in other parts of the country. I know here in Arizona, for example, I had a conversation with Haley Coles, who heads up Sonoran Prevention Works, one of the largest harm reduction organizations in Arizona. And she was telling me that mostly fentanyl is coming across the Arizona border in the form of pills. And most of the users now have gone to smoking rather than injecting the fentanyl, because it's just, easier practically to crush the pills and then smoke them as opposed to liquefying for injection, which, by the way, is a little safer too, because when you're smoking it, you could adjust the dose to the desired effect, whereas when you inject it, it's all in there and you can't stop it if it's too much.
Well, and that's a great segue for us actually into sort of the next piece of this conversation. Just one quick note, we do feel free to put your questions in the chat or in the Q&A, but we will get to those at the end. So if you put something in there already and we haven't responded yet, it's because we're going to save those to the end so we can get through this part of the conversation. But so obviously people who are using drugs and at risk of overdosing from fentanyl are obviously active human beings making decisions of some sort, right? As they go about their consumption. So I think it's really important to talk a little bit about how the ways people have used are changing, right? Like, are we seeing increases of folks smoking? Are we seeing folks doing things like, Lucinda, you mentioned earlier, test shots? That's something that it's definitely worth talking a little bit more about. So Mona, if you don't mind jumping off with, how have you seen the presence of fentanyl affect people who are using drugs, both in terms of the behaviors that they're engaging in and maybe drugs that they're choosing to use or not use?
We are seeing people who are preferring fentanyl. They are seeking out fentanyl, and they use the fentanyl test strips to look for the presence of fentanyl. That's a big one. We are distributing so much Narcan. We are seeing a lot of fentanyl in pressed pills. So we're especially seeing people who take pills for partying, checking their pills, requesting fentanyl test strips for that. They necessarily don't want fentanyl, or at least they want to know what they were dealing with, wanting an informed consent so they can take their drugs in a safer manner.
Yeah, thanks. And then Lucinda, have you seen something similar? Have you seen different trends in Washington?
Yeah, some similar trends. Fentanyl is a tough adversary. People who use it often have a love-hate relationship with it. The rewards are intense, but short-lived. Just a few hours before withdrawal symptoms occur. And then there's an urgency to use more. People will smoke it. Most of the time they're smoking it and not injecting it. And they'll do that 5, 10, or even 20 times a day, more frequently than heroin use. They usually smoke it instead of injecting it because as for the reasons that were discussed. And in some ways that's good because it leads to fewer skin and soft tissue infections. I do worry that it may also lead to less reliance on syringe services programs where people can get access to a whole range of other services and some contact with the treatment community. The biggest thing, though, is that when someone decides that they're fed up and they want to get out of that cycle, it's extremely difficult to get out of it. It digs its hooks really deeply. Stopping cold turkey is hellish, much worse than quitting heroin cold turkey. Yet transitioning to medications for opioid use disorder is a big challenge. Transitioning to Suboxone, buprenorphine, is very difficult due to precipitated withdrawal. That's because buprenorphine is a partial opioid agonist, in contrast with fentanyl, which is a pure opioid agonist. Buprenorphine partially reverses the effects of fentanyl and can cause an intense opioid withdrawal syndrome, somewhat like naloxone, and that can go on for days. So that's difficult. Transitioning from fentanyl to methadone, however, while it's gentler, it's very difficult because it's difficult to access because of the extremely tight federal regulations.
So to make sure I know Jeff has a question for Mona. I have a quick question about the difference. So just to make sure I understood right, like transitioning folks onto buprenorphine from fentanyl is harder on them than transitioning them onto methadone, if you can get actual access, lower barrier access to methadone. But as we know, low barrier access to methadone is extraordinarily hard to come by. Okay.
Exactly.
Okay. Interesting. Yeah. And Jeff, I know you had some questions for Mona, but maybe also something
Yeah,
else. Another
and
thought.
also for Lucinda. So first of all, Mona, back in 2019, Professor Dan Ciccarone, you may know of him from UC San Francisco, he spoke at the Cato Institute. He was doing the heroin in transition study for the NIH. And at that time, this is before fentanyl became as dominant as it is now, he was learning from people who use drugs that they actually preferred, most of them, there's always some different taste, but most of them preferred heroin. It was a completely different experience. I remember him saying heroin felt warm and fuzzy, and fentanyl felt bold and brash. And it was their preference to get heroin. And then as the market started only providing fentanyl, because it was more efficient for the cartels, they just sort of got used to using fentanyl instead, because you take what you can get. Is that what you noticed? Where you work in Georgia?
Yes, that's what we are noticing, that people are saying, hey, there's no more heroin out there, or there's very little heroin out there. So there are people who just and also people are just presuming that fentanyl is in every substance that can hold it. So people are again, they're actively looking for fentanyl, or they're just making sure that they have a lot of Narcan, and dealing with whatever they are sold.
And then I wanted to ask Lucinda, when the current Dr. Rahul Gupta, the current so-called drug czar, originally proposed among harm reduction materials to get out or smoking equipment. Of course, that got demagogued by a lot of politicians and by the media as you're giving crack pipes out to people so they can smoke crack. But what I've learned from people in the harm reduction community is that now that more and more people are smoking rather than injecting opioids, which, by the way, that's much more common in Europe too. They've tended to smoke there more than inject. They're sharing dirty, broken, sharp-edged smoking equipment, and actually giving out clean smoking equipment is similar to giving out clean syringes, and that it shouldn't be derided. And it's also a way to get people to come to syringe services programs and get the other benefits of it. So I'd like you to talk about that.
Yeah, absolutely. So smoking supplies, if you're using something that somebody else has used, you're more likely to get access to hepatitis C infection or HIV infection, mostly hepatitis C, which can be transmitted so easily. So providing access to clean smoking supplies is really essential for that reason, and also to get people to have a reason to go to the syringe services program so that they can get other kinds of healthcare needs met. So yeah, I do think access to clean smoking supplies is really important, and it's totally misunderstood.
Yeah, and specifically, I mean, it's right, some of the same viruses that we worry about with syringe sharing can be transmitted when folks are sharing used pipes that especially have sharp edges, right? Hepatitis C is one of the one of the most challenging ones in that regard, because it's a pretty tough virus, and treatment is extremely expensive, and a lot of folks don't necessarily realize they have it until they have pretty severe case. So thinking about, we've talked a little bit about how fentanyl has changed the way that folks are using drugs. How has it changed the way that you and your fields are working with those people? So let's start with you, Lucinda, in part because you talked a little bit already about sort of that challenge of getting folks onto bup versus maybe getting folks onto methadone. Let's sort of start with that harm reduction based treatment, and how has that changed, if it has, in the age of fentanyl?
Yeah, absolutely. Well, first, I'd just like to mention, echoing Mona, the incredible need for access to naloxone. In Washington State policy and harm reduction circles, there's been a shift in emphasis towards increasing access to naloxone, in addition to increasing access to medications for opioid use disorder. This is because the immediate and urgent need is to save lives, and naloxone is the way to do it. However, as what you're referring to, Stacy, second, there's a consternation in the addiction medicine community about how best to help people transition from fentanyl to buprenorphine. At several conferences that I've been at lately, there have been a whole lot of different presentations on this very issue. And there's no one reliable technique that has been developed to help people avoid precipitated withdrawal and to get onto buprenorphine quickly and smoothly. There are several strategies being used. One of them is microdosing. That's the use of steadily increasing doses of buprenorphine over the course of days, starting with an extremely low dose that is too low to cause precipitated withdrawal, and often while continuing fentanyl until an adequate level of buprenorphine is achieved. Another approach is macrodosing. That is providing a large amount of buprenorphine all at once, quickly, with the intent of flooding the opioid receptors, displacing fentanyl. A recently proposed approach is to use macrodose preceded by having the person self-administer naloxone to intentionally clear the receptors of fentanyl, making room for buprenorphine. And when most people hear about this in the healthcare community or among people who use drugs, it's shocking to even think about it. But apparently that precipitated withdrawal experience is very short-lived, like less than an hour, and people can actually get stable fairly quickly. Finally, and this is a strategy that I'm developing myself with very promising results, is the use of microdosing of ketamine given in a sublingual lozenge format, and that can completely wipe out or prevent precipitated withdrawal. I've now treated about 10 people this way, and a case series manuscript is currently under review. I'll also be presenting those 4 of those cases at the upcoming annual meeting of the American Society of Addiction Medicine.
Wow. So it's really sort of constantly adapting and figuring out. And it sounds like sort of finding what works best for each individual at this point, or?
Well, it turns out that it's kind of like an individual clinic will choose a strategy that they want to use and try to perfect it for their setting. There's not a lot of individualization for each patient because you don't really know how that patient is going to respond. So you just do your best to try to optimize your own strategy.
Yeah, that makes sense. So Mona, thinking more in terms of the harm reduction side of things, maybe before folks are ready for treatment or while they're sort of making that transition, what are you seeing, and how have the services that you've provided had to shift and change and adapt? You've definitely, you've mentioned the importance of Narcan and raising awareness among different populations, but can you talk a little bit about that, and then any other services you haven't mentioned before, or education?
Well, Georgia Harm Reduction Coalition does have a connected care clinic, and we provide buprenorphine. So we actually provide a nurse at our outreach, at Thursday outreach, especially to talk about, so that she can talk about the intricacies of MAT. We try to promote that when and wherever we can. We're just trying to sling as much Narcan as possible. That's it feels like, I don't know, we're a few drops of harm reduction in a great big barrel of need, but we're going to keep dropping and keep looking for more and better strategies. We're working with other syringe service programs in Atlanta and in Georgia to see what's working in the city of Athens with Prevention Point, Georgia, in Atlanta with the Elizabeth Foundation. So we're just trying to keep up with things, because it seems like so much is coming so fast. Xylazine, ISO, pyro. What's next? So we're just trying to keep the lines of communication open.
Yeah, so on the ground, harm reduction folks, like recognizing that the market's changing and the drug, like the reality of the drug environment is changing. How do you get ready for these potential new substances?
We keep talking to the people we serve. We have formal surveys, and then we just shoot the bull. And sometimes I just ask, how's the drugs? Everybody laughs, but then we have conversations about what people are seeing. So it's constant communication with the people we serve.
Yeah, that definitely makes sense. And so shifting a little bit back to this harm reduction based treatment, right? So medications for opioid use disorder. Let's talk a little bit about take-home methadone, and especially because this is something that has come up, as methadone is actually much easier to help folks who've been using fentanyl either by choice or not as their first choice. What do we think about take-home methadone and reducing those particular barriers? Jeff, why don't we start with you?
Yeah, as Lucinda mentioned, for those who are not in the medical field, buprenorphine sometimes could precipitate withdrawal. It's very kind of, you got to negotiate this little tightrope to have it kind of hit the sweet spot when you're trying to get a patient on buprenorphine. You don't have that problem with methadone. And in Canada, the UK, and Australia, doctors, primary care providers have been able to prescribe methadone as a take-home medication since the 1960s. So, you know, if we come to look at substance use disorder as a health disorder, not a vice or a moral failing, which unfortunately too many people do, then just like we could treat high blood pressure or diabetes by prescribing medicines and having our patients follow up with us, we can do the same thing with substance use disorder. And it's complicated, so not every primary care provider would want to do that, but some have an interest in it. So during the pandemic, well, first of all, in this country, in order to have a methadone center to treat someone, it's regulated by the Drug Enforcement Administration. The regulations are very onerous. And then on top of that, there's this not in my backyard phenomenon where a lot of neighborhoods say, I don't want one in my neighborhood having all these drug addicts coming over here. So for many people who could otherwise access methadone, it's very hard to get to them. And then they require you to take the medication in the front of a person on the staff because you're an addict, so you can't be trusted. And again, there's a stigma attached to the whole way these people are treated. So those requirements are very difficult for a lot of people to make. So many people have to travel long distances, have to stand in line. And during the pandemic, because of the problems with lockdowns and infection, the methadone clinics had a temporary relaxation. So people who were, quote, stable methadone clients were given, I think it was 30 days worth of take-home methadone. And people who were less than stable, which I think meant they were on it for they were in the program less than 6 months, were given 14 days. And studies have shown it didn't result in them, selling it on the street and all that kind of stuff. It worked very well, just like it works in all these in these other countries I've mentioned. So there's one of the things that can be done is if we let methadone, as a surgeon, I can and have prescribed methadone for the treatment of pain. I'm allowed to do that. That's what it was invented for. But I'm not allowed to prescribe it to prevent people from withdrawing from addiction to an opioid. So one of the things we could do if we're really interested in helping reduce overdose deaths is allow primary care providers who want to treat substance use disorder to prescribe methadone the same way they're allowed now to prescribe buprenorphine. And there was a bill introduced in the last session of Congress by Congressman Norcross of New Jersey that had bipartisan support. But the only problem was it only allowed board certified addiction medicine specialists to prescribe take-home methadone, which, in some states, like in Wyoming, there are 2 board certified addiction specialists in the entire state. We should allow primary care practitioners who are interested in treating substance use disorder. Not every primary care practitioner is going to want to do that. It's complicated and it involves a commitment, but we should allow them to do that.
Can I comment on that? Yeah, it would have been fantastic, I think, if that bill had been able to pass, at least as a beginning stage, at least get enough people prescribed methadone so that the world can see that they're not all going to die of an overdose. And advancing it to all primary care physicians, it would be really nice if we could have a 2-stage process, get it started at least with the addiction medicine providers prescribing it directly to people for take-home use. And then maybe a little bit later, I don't know how long it's going to take, but not that long afterwards, let primary care providers do it too.
Yeah, Mona, did you have any thoughts on take-home methadone, or before we move to questions from the audience?
The people who got those 2-week 30-day supplies really liked it. They loved it. They loved the convenience. They felt free from the chain of a methadone clinic. So I hope there can be ways to bring that back, get methadone to the people who want it.
Can I clarify my comments? It's not that I'm opposed to having primary care physicians be able to prescribe it. I think that would be absolutely terrific. I'm just thinking about political realities, what could actually possibly pass Congress. And it might be easier to pass something through Congress if it was limited to addiction specialists. If a widespread support could be developed among all in Congress to let all prescribers prescribe it for take-home use, I think that would be terrific.
Yeah, no, and I think that's that convenience piece, right? The fact that, like you said, Mona, your clientele really appreciated having that. Some of the studies I've read, one of the things they talked about with take-home methadone during the pandemic was like one woman who was a mother talked about she couldn't really get childcare necessarily for her child every time she had to go to the clinic, but she also didn't feel comfortable bringing her kid to the methadone clinic with her all the time. And so it made a huge difference for her, not just in convenience, but in like the way she was able to provide care for her child. And a lot of people talk about things like work issues, right? Like how can they get time off of work to go every day if it might take multiple buses and standing in line and all of these other issues. So there really are a lot of practical factors at play, it sounds like, with all of this as well. We've only got about 10 minutes left, and I feel like you all have done an amazing job of highlighting sort of our final questions, which is going to be things like, why is harm reduction so important in the age of fentanyl and other synthetic drugs? So I want to go ahead and move to the questions that our audience members brought up. And I wonder, Jeff, and if others have a specific response, but I feel like this is definitely Jeff's wheelhouse. Can you briefly talk a little bit about if and what China's role might have been in the production of fentanyl?
Well, it's easy to beat up on China. Everybody wants to hate China right now. But the ingredients to make fentanyl in a laboratory are very available. For example, the main ingredient, piperidine, is used to manufacture dozens and dozens of pharmaceuticals. So unlike acetic anhydride, which doesn't have as many commercial uses, it's in abundant supply. Now, many companies in China make it, and the cartels in Mexico and other places south of the border purchase it from them. But, you know, if the Chinese government were to crack down on it and not let piperidine to be sold there, well, first of all, the pharmaceutical companies need piperidine, so it's going to get made. And if it's not going to be made in China, it's going to be made in Vietnam or Thailand or somewhere else. So I just think it's a fool's errand to blame it on a country and go after the country, because if there's anything we should have learned after 100 years of actually 110 years of drug prohibition, it's like you're pushing in a balloon. So you put your finger in one end and it comes out the other. We cracked down on the cocaine production in Peru, so it moved to Colombia. Then we cracked down on cocaine production in Colombia, it moved back to Peru. So the bottom line is, as long as you're going to crack down more and more and more, then you're doing your best to make sure that 2 or 3 years from now, we're going to be talking about the nitazene crisis, not the fentanyl crisis. And then after the nitazenes, it'll be something else.
Yeah, for sure. It's just a little bit of whack-a-mole when
Yep.
when we're approaching it from that direction. So another question from an audience member relates specifically to some legislation around medications for opioid use disorder and the MAT Act. I don't know how familiar folks are, but this would increase lower barrier access, right? So does anyone have any thoughts about how the passage of the MAT Act may or may not help reduce the harms associated with fentanyl? We can.
I'd love to talk about that. I was involved in promoting or recruiting Congress people in Washington State, and 8 out of our 9 Congress people became co-sponsors of the MAT Act. And I think over half of Congress people in a bipartisan way ended up supporting it. The main thing I think that's going to be the advantage there is the impact on stigma, especially among healthcare professionals, because people have been afraid to even think about doing it because they think it must be something dangerous or hard to do, because only a select subgroup of people are allowed to prescribe it. And healthcare providers, once they realize that actually they are not only entitled to, but they should feel that it's their responsibility, that's going to remove a barrier. There's still a lot of stigma that's going to interfere, and a lot of work needs to be done to reduce the stigma, but at least there won't be the same fear among medical providers.
Stacy, I've actually written about this. On the one hand, I was very gratified to see that they removed the requirement to have the so-called X waiver, which has stood in the way of a lot of practitioners from wanting to prescribe buprenorphine because it's such an onerous bureaucratic obstacle. On the other hand, I think they passed it along with the MATE Act, which now is going to require every single practitioner in the United States who has a DEA narcotics license to prescribe any narcotics, like me. I prescribe pain pills after I perform surgery on people. We're going to have to take an 8-hour course.
No,
they're not going to do that.
I don't know that it has to be the full 8 hours. I don't think that it's the language was not specific to 8 hours, and I think it's still up for grabs about exactly what that education is involving. But every medical provider has to do some kind of continuing education anyway. So this would just be one of the things that they would need to include.
Except in 42 states, they already require this. Like in my state of Arizona, every time I renew my license, which is every 2 years, I have to take a 3-hour course. So that if I want to be able to legally prescribe narcotics in Arizona, and 42 states have a similar requirement. And my understanding is they're going to add another requirement on top of that. And so far, there's no evidence it's done anything to stem the fentanyl crisis, because we're not prescribing fentanyl, and especially not fentanyl in conjunction with meth or cocaine. I can't remember a single clinical situation where that made sense to do.
Yeah, I agree. There's a lot to talk about on this one topic, but it's probably not the most important thing for us to address in the remaining minutes.
No,
that we
but
have.
I'm
So
worried
maybe
that it may discourage a lot of doctors from renewing their narcotics license, because especially those who don't prescribe a lot. And then people who need pain medicine it's gonna get even harder for them to get relief of pain, which we already see a lot of pain patients are becoming pain refugees because nobody wants to treat their pain anymore.
I'm totally on the same page with you about all of that. But let's talk about the other things that policymakers can do in order to help these people that are struggling with opioid use disorder. And we can talk
Yes.
about this other stuff. I'd love to do that.
No, and I think the points are really important, right? Like a lot of the time legislation has a lot of really good sides, and there might be some unintended consequences that are associated with that, or intended consequences that have a bigger ripple effect, right? That make things even more difficult. But yeah, as we sort of go forward and wrap this up, we've only got 3 minutes left. I'd love to hear 1 or 2 key takeaways that both state and federal policymakers should bring home if they're worried about fentanyl overdoses in their communities. And let's go ahead and start with you, Mona.
More treatment, more alcohol and other drug treatment, because that's in short supply, especially if you have no money, no insurance. It is a bear to try to get someone homeless, no ID, no birth certificate, into treatment. Is there any way to make that easier? And hey, let's have more harm reduction. Let's teach our policymakers about harm reduction. A lot are getting educated through Good Samaritan laws, naloxone access bills, but we can teach our policymakers about what we need them to learn and guide their policy.
Thank you,
Can
Lucinda.
I jump in really quickly?
Yeah.
Yeah, I just want to say, how do we get people to have the money to have treatment, Medicaid expansion? That makes a huge difference, because most of the people that are really the highest risk of opioid use disorder, of dying from it, they're living in states where they don't have access to Medicaid. And the states like Washington State that do have Medicaid expansion, most of the people at the Olympia Butte Clinic, for example, are people who would not otherwise have qualified for Medicaid, and they can get it for free because of Medicaid expansion. So all you people listening from states that don't have it, try to get it there.
Thanks. And Jeff, do you have a final thoughts for policymakers on
Yes,
this?
I would urge policymakers to not, it's attributed to Albert Einstein, but I don't know if he really said it, but the definition of insanity is doing the same thing over and over again and expecting the same results. So I encourage policymakers to stop doubling down on the same policies and expecting a better result, because all you're doing is making sure that the iron law of prohibition is healthy and working. Other things that I would recommend is that policymakers remove obstacles that are right now in the way of harm reduction organizations trying to help people. So like we talked about, allow take-home methadone. It looks like naloxone is finally going to be made over the counter, probably sometime in March. That's great. It should have been done years ago. Buprenorphine is now—
price. Lower the price.
Once it's over the counter, the price comes down. That's what happens to everything. And also, I really think it's important for Congress to repeal 21 USC section 856, also known as the crack house statute. That's why safe consumption sites, really better called overdose prevention centers, are federally illegal in this country. There are 147 of them in the world, in 91 locations, in 16 countries since the 1980s. And the United States is now an outlier because it's federally illegal in this country. So if we remove barriers, there are a whole lot of groups, harm reduction organizations, many of them privately funded, who want to help their neighbors, but they're being barred from doing so by laws.
Awesome. Well, thank you all so much for taking the time today. Thank you to our audience for taking the time out of their day to listen and to ask such thoughtful questions. Yeah, if you have, we'll be sending, I believe, a recording around, and if anyone has any additional questions, you know how to reach us at our street. So thank you so much again to my panelists, and I hope you all have a great day.